to address for you whether ACL injuries can be reduced, not prevented. Prevented would mean that we would know a specific ACL injury was going to happen ahead of time. So we're going to talk about ACL reduction in both the primary and the secondary ACL injury setting. These are my two academic daughters, Carmen and Katie. They were in our prospective cohort studies in 16 years old, and at 17, they both tore their ACLs. This is them receiving their terminal PT, PhD, and MD, PhD degrees. What you can see is Carmen on the left. She retore her graft very soon after, within a year of surgical reconstruction. Katie tore hers several years after, but at 13 years post first surgery, they now have had cartilage resurfacing procedures. And the problem is Carmen and Katie are more the rule than they are the exception. What we do is we use a method we call preventive biomechanics, and we use this in exercise studies, neurological situations, cardiovascular disease. I'm going to show you some of the genetic information that we have related to ACL injuries, but we also use it for other diseases like cardiomyopathy. The long-term impact of an ACL injury is great. Former NFL players who have tore their ACL have a twofold increase in musculoskeletal comorbidities like arthritis and knee joint replacement. However, very problematic is that they also have a 50% increased risk of myocardial infarction compared to those without ACL tears. We're currently looking in a very large cohort data set to see if this is the case. So if we're going to get at reduction of these injuries, first we have to examine the mechanism from a body habitus standpoint. We have this lower extremity valgus or knee abducted position with low knee flexion at landing, with a single leg on a flat, often rotated foot, with the center of mass displaced away from the foot base, with the trunk moving in an uncontrolled fashion. Now, if we zoom down on the knee itself, what we see is, if this is my fibula, what we have is a combination of what we call knee abduction, with the distal tibia moving away from the midline of the body, anterior translation of the tibia, especially of the lateral tibial plateau, coupled with internal rotation applied very rapidly, and the ACL ruptures. Now, here's the good news. This is an early meta-analysis that we did several years ago when 12 studies were published, and which shows that the efficacy of this reduction is about 62% overall. And this funnel plot in the Journal of Bone and Joint Surgery from a German group shows that not only does this occur at about a 62% rate, that's that central line reduction in the odds ratio, but it's also not a positive publication bias. As you can see, all these studies fall within the realm of the funnel plot. We recently did, with Kate Webster out of Melbourne, Australia, a meta-analysis of all the meta-analyses of ACL reduction programs in the literature that we published recently in the Journal of Orthopedic Research. And we showed a 67% reduction in ACL injuries, non-contact, especially ACL injuries in females, 50% reduction of all ACL injuries overall. Again, what you see here is a forest plot demonstrating the favorable 50% reduction in all injuries and a 67% or 2/3 reduction in non-contact female ACLs. So we can reduce all ACLs by 50%, non-contact ACLs in females by 2/3. We also published this consensus in the National Athletic Trainers Association journal, the Journal of Athletic Training, and demonstrated the same thing, that overall you see a half reduction overall, 2/3 reduction in non-contact ACL injuries. This is a clinical practice guideline that we published in the JOSPT with the sports section of the APTA. And this is a very nice reference because it has online tutorials and videos to show all the latest ACL reduction techniques. Again, in order to get at how to reduce an ACL, you have to look at the mechanism of failure. So in the 1980s, we looked at isolated ligament ruptures, basically pulling the knee joint apart, and showed that took somewhere between 1,800 and 2,200 newtons of force, or about 500 pounds of force to tear an ACL apart. After the uniaxial studies, we did robotic manipulations where we demonstrated the loads during a drop vertical jump maneuver, simulated these tasks, and showed the strain and the failure requirements of this coupled, as I said, abduction, anterior translation, internal rotation to rupture the ACL. So our group then developed the first injury-driven mechanical impact simulator using combined approaches. And what we could do is produce clinically relevant injury patterns. And we demonstrated this using our Mayo Impact Stimulator. Current version is 3.3, but basically what we did is apply loads that occurred during a drop vertical jump maneuver and kept ramping up the loads until we rupture the ACL, as shown here. Our surgeons would do a pre-mechanism exam, and then after going through our simulator, they would do an arthroscopic exam and demonstrate ACL ruptures just as they appeared in surgical arthroscopy. And they were highly relevant clinical ruptures: femoral eversions, complete mid-substance tears, and partial mid-substance tears. We compared that to our prior simulator in blue, the current simulator is in red, and to the clinical literature. And what we show is we have very clinically relevant presentation and rupture outcomes as we get primarily femoral side avulsions, mid-substance tears, and then tibial side avulsions as well. Many people believe that fatigue causes ACL injury. Well, in skiing, for instance, it always happens on the last run of the day. Well, there's really no evidence that supports this. If you look at the timing of ACL injury, say in the first quarter versus the fourth quarter, if there's any tendency, it tends to be early on. This is from a meta-analysis we published just a couple of years ago. And if you look at our ACL prevention consensus statement, which is a very large manuscript, if you look through there and you search fatigue, you get 0 hits because fatigue doesn't cause these ACL injuries. Now, psychological mechanisms are indeed at play. If you look at psychological responses, for example, during rehabilitation, it's really that Goldilocks just right spot, because it's a U-shaped, an inverted U-shaped curve. Athletes that are on one end of the curve with high anger or high fear have increased risk of a rupture, where those that have limited anxiety, limited fear, a reasonable amount of confidence are at the lowest risk of a second tear. So after the ACL tears, you have altered movement biomechanics, and we hypothesize it's because of the loss of the sensory receptors. There's all 4 types of neuromechanical receptors in an ACL that are lost, that are not gained with the ACL reconstruction. And with that sensory loss, you get pain and arthrogenic muscle inhibition, chronic swelling, inflammation. You get knee muscle atrophy and joint structural changes. And then we can monitor that via the symptom of these altered movement biomechanics that we see even 2 years out post-operatively. And if you look at bone health, if you look at Scott Dye's work, this is a series of studies that we did on MRI in our patients. And basically what this shows is with that abduction, anterior translation, internal rotation, you get posterior tibial plateau bone bruising, anterior lateral femoral condyle bone bruising, showing that valgus mechanism of injury. And Scott Dye's work in bone scans shows that bone bruise stays hot for 18 to even 24 months post-injury. There's also significant knee muscle strength decreases and atrophy of the muscles, especially the quadriceps muscles, but especially in the hamstrings if a hamstring graft is used. This is Baron Davis tearing his ACL graft. This is the graph tearing, and what you see is this combination of this extended hip and knee, internal rotation of the head of the femur, hip and knee AD and AB duction, and rupture of the graft. So the outcomes after ACL reconstruction remain questionable and challenging, and there's varied return to sport success after ACL. Only about 50% after a year, and only about 2/3 after 2 years. And these athletes, after losing that sensor in their knee, demonstrate these abnormal neuromuscular strategies, high incidence of OA, and a high incidence of second injury, between 1/4 and 1/3 if they're young, physically active, going back to the same sports. So current randomized controlled trials underway are looking at current rehabilitation guidelines and then using targeted neuromuscular training to see if we can get better outcomes. So what we're doing is addressing the outcomes of ligament dominance, quadriceps dominance, limb dominance, and trunk dominance, and moving toward technique perfection before we let the athlete go back to sport, passing our drop vertical jump test for all these different parameters. And then we use multiple phases of dynamic stabilization, functional strength and power, side-to-side symmetry, and core strengthening. If you're not going to use objective criteria to return an athlete to sport, you should consider waiting 2 years, because timing does not directly correlate to function. So very targeted return to sport protocols should be used, and used serially, to look at increase in function, increase in improvement in psychological parameters before an athlete is allowed to return back to sport, in order to decrease the relative risk of injury. Finally, there's some genetic data, the family pedigree of Carmen and Katie. They're the identical twins at the bottom here. This is one generation up, is their dad, Jim, and his 2 triplet brothers, all with bilateral ACL injuries. Recently, one of the brothers died of a heart condition. So I want to thank you for your time. I appreciate it. I look forward to questions. Thank you very much.